Excuse me. That was a terrible time to start the audio recording. Alright, principles of pharmacology. I apologize if the audio is not very good. I haven't used the internal microphone on the computer as opposed to my plug-in microphone this time because I can't find it. Oh, why are you not working? Give me a second. There we go. Now it's working. Okay, so even at an EMT basic level, you're going to have the opportunity to administer certain medications. And you have to understand that administering medications is an incredibly important task. It is one of the most common times in which we make an error in our care. Our goal is to try and help alleviate a patient's symptoms or promote their ongoing health after whatever condition they called you for arose. So either alleviating pain, alleviating symptoms, helping to stop the progression of symptoms, something along those lines. Especially once you get on further in your EMS career into the AEMT or the paramedic level, you'll use these same principles of pharmacology throughout. And you'll understand that the goal of the medication is to improve the patient's condition, but that every time you give a medication, you have the potential to harm a patient if you use it incorrectly, or do not pay attention to what side effects might occur as a result of you giving that medication. The old sort of adage is if you don't know what a medication does or what it could do, you better not be given that medication. So if you ever find yourself in a situation where your protocol expects you to give a certain medication and you don't know what that medication does, until you have researched it and identified what that medication does and what you can expect it to do if it works improperly, you should not be giving that medication. Okay, so pharmacology is the study of how medications or how chemicals act on the body. When we talk about pharmacology, specifically, we're talking about the science of medications, the science of their ingredients, the science of the preparation, the mixtures, the uses, the actions, the contraindications, etc. This is just sort of a general definition of medication, something that is designed to help prevent or alleviate symptoms of a disease. Okay, pharmacodynamics. There's two primary concerns in pharmacology. There's pharmacodynamics and pharmacokinetics. Pharmacodynamics is how a medication works. There are various types of medications. They all work in various ways. Some medications work on one part of the body one way while another part another way. Every single cell in our body has specialized receptors located on the surface, and medications are designed to interact with those receptors in some manner. There are certain classes of medications that respond to receptors inside of the cell by passing through the cell membrane before causing their action, but the vast majority of them work on receptors on the exterior of the cell. Sorry, I accidentally skipped forward. And I apologize that it's cut off at the bottom. Okay, a couple more definitions. An agonist is something that stimulates the receptor. It causes the typical reaction that would occur if that receptor was stimulated. So for example, a beta site on a bronchial smooth muscle cell causes that smooth muscle to relax, allowing the bronchial to dilate. A beta site in other parts of the body may have different actions. For example, a beta site in the skin will always constrict in response to beta stimulation. So an agonist is something that mimics the normal way that cell is stimulated. So it stimulates the receptor. An antagonist is the opposite. It is something that prevents the cell or decreases the stimulation of that cell or that target site. There are a couple different ways that something can be an antagonist. There are things known as competitive antagonists, which are ones that compete with the normal chemical that binds to that site without doing anything. So Narcan is a form of competitive antagonist. Y'all won't necessarily be able to give Narcan at the basic level, but you'll probably hear about it. Narcan is medication that's used to overcome the effects of opiate overdose. So Narcan, or naloxone, binds to the opiate sites in the central nervous system. It prevents the opiate pain medication from binding to that site because that site's already occupied by naloxone. However, naloxone does not stimulate the cell or does not stimulate the receptor in the same way that an opiate medication would. So therefore, it's preventing the opiate from working by taking up the space that the opiate otherwise would have occupied. Dose is the amount of medication that is given. It's not necessarily the amount of medication needed. The appropriate dose, or the dose range, is the amount of medication that is needed. Most medications have some sort of dose range, and we generally prescribe or fall within that dose range. Often you'll hear a term, the minimum effective dose, and this is stating within that dose range, what is the minimum amount of medication that I can give to see the full therapeutic benefit. Many medications are given just as straight doses. Aspirin, for example, if you're taking it daily, it's 81 milligrams. If you're giving it in an emergent situation, typically 324 milligrams. Doesn't matter how big the person is, what sort of medical conditions they have otherwise. I mean, we'll talk about it more, because there are some medical conditions that adjust that or change that. But generally speaking, we give the exact same dose every single time. It is slightly different with age. We don't give aspirin to young pediatrics, but it's not weight-based. However, there are weight-based medications. There are none that y'all will have to worry about that are weight-based, though. Action is the intended therapeutic effect of the medication. So when I talk about the action of albuterol, the action of albuterol is to decrease bronchial constriction and decrease bronchial inflammation within the lungs. And that is the action, the expected, the intended effect. The indication is the reason that you give the medication. Okay? Why is it that we're giving it? So we'll use albuterol as the example again. The indication for albuterol is bronchial constriction or bronchial inflammation, identified by wheezing when the lung sounds are auscultated. So that's the indication. Okay? So the indication is not what the medication does, it is why the medication is given. Aspirin is an antiplatelet aggregation medication, but you don't give aspirin because of increased platelet aggregation, so it's not always the opposite. You give aspirin because of a suspected myocardial infarction, or you give aspirin because of a suspected pulmonary embolus, something along those lines. So the action and indication are related, but they aren't always necessarily the opposites of each other. A contraindication is a specific reason you would not give the medication. So the sort of hallmark contraindication to every medication is what's known as hypersensitivity or an allergy. So if I'm allergic to aspirin, I'm not going to give that patient aspirin, right? If they're allergic to it, they can't take that medication. They might get the therapeutic effect from that medication, but they'll end up having a significant negative reaction to that medication as well. Anytime we talk about contraindications, we're talking about the reason you should not give a medication. Keep in mind that a patient will often tell you they have an allergy to a medication, when in fact what they have is side effects from that medication. So you got to kind of weigh whether or not the side effects outweigh the benefit of giving a medication. Those are not necessarily contraindications. So the side effects are actions that the drug has. They're actions that are somewhat expected, but that are not desired. So we'll go back to albuterol as the example. The intended action of albuterol is to decrease bronchial constriction, decrease bronchial inflammation. However, it also tends to cause the heart rate to go up, it tends to cause the blood pressure to go up, and tends to cause the respiratory rate to go up. Those are all side effects. They're unintended effects or unintended actions of the medication that go along with the action. We can expect that somebody's heart rate will go up. If it doesn't, great. If it does, we understand that that's part of what that medication gives. So those can be broken down further and into unintended effects. They're undesirable, but they don't necessarily put the patient's life at risk. Albuterol, tachycardia, increased blood pressure, increased respiratory rate, all unintended effects that are not necessarily problematic. They're expected. Untoward effects are those negative reactions or those side effects that have the potential to lead to actual harm of the patient. Aspirin, for example, if we start giving aspirin and we didn't know they had a GI bleed or a gastrointestinal bleed, and their gastrointestinal bleed starts bleeding significantly more and they become hypotensive, that's an untoward effect. We understand that aspirin may be able to cause an increase in bleeding, and because they were already bleeding, now they're bleeding more. That's an untoward. It has the potential to cause harm to the patient. All right, all medications generally have a generic name and a trade name. The older a medication gets, the less common the trade name becomes, and the more common the generic becomes. But I really want y'all to focus on recognizing the generic names because they're less prone to misunderstanding what they are. They have a general naming convention, usually, based off of the chemical structure, and they aren't marketing hype. So they're less confusing. However, you need to recognize what some of the trade names are for various generic medications. So, in this example, we're using the generic name of acetaminophen, which is Tylenol. The trade name is Tylenol. It's specific to the brand. But recognize someone could say they take Tylenol, or they take Bayer, or they take Excedrin, or I'm trying to remember, Chlorocedrin. All of these things have acetaminophen in them, and that's one of their active ingredients. So somebody giving you the trade name, unless you know those trade names really well, it doesn't tell you what the actual medication is. Tylenol has nothing to do with what's in the medication. Acetaminophen is the name you need to understand. And if you ever hear a trade name, you need to try and understand that if you don't know what's in it, you need to look it up and find out what the actual medication is, what's in it. Prescription medications, I'm not sure why we need to define that, but basically must have a physician's order, cannot be bought by the patient of their own fruition. They have to be purchased at a pharmacy. The pharmacy has to fill the order and the doctor has to approve the order. Over-the-counter drugs are kind of the opposite. You can purchase them by yourself kind of whenever. There's kind of a specialized class of medications that require pharmacist approval. Those are things like pseudoephedrine that you have to go to the counter to purchase, but you don't need a prescription to purchase. And then obviously you have things like street medications or street drugs, herbal medication, enhancement medications. It's talking about things supposed to enhance your libido. It's those things you see in shady gas stations at the checkout counter. And then vitamin supplements. And not so much at this level, but the further you go in your education, you're going to have to understand how all of these medications potentially interact, or all of these drugs potentially interact with the medications that you plan on giving. There's a number of herbal medications that affect the actions of aspirin. There's a number of street drugs that affect the effect of benzodiazepines, which are medications given to seizure patients. Vitamin supplements can have huge effects. Somebody that takes a super high level of vitamin K may be at risk for coagulation disorders, meaning they're hypercoagulatable. So keep that in mind. All right, routes of administration. You just kind of need to know these definitions. You don't necessarily need to know all of them super well, because not all the medications you're going to be concerned about go through all of these routes. So enteral, anytime you hear the word enteral, we're talking about through the digestive tract. It's absorbed through the digestive tract. Parenteral is anything else. Any other way that the medication ends up in the body other than the digestive tract is parenteral. Beside enteral. I don't know why they use that as the word, but that's what they use. Okay. Absorption is how the medication gets into the bloodstream, how it is absorbed, and each medication will have a specific absorption pattern. Rectal, PR, typically used in children. Young children don't typically use this medication method in 8-9-year-olds, but birth to a year or two, pretty common. It's also common in other patients who are incapable of taking enteral medications. They're unable to swallow, unable to keep stuff on their stomach. So severe nausea and vomiting. They're very easy to administer. They're very reliable, very quick absorption, but somewhat odd psychologically for some patients. Intravenous, anything that's directed directly into a vein. It's the fastest delivery route. It spreads throughout the body very quickly. Cannot be used for a number of meds because we don't want the actions to onset as quickly as IV administration would allow for. Intraosseous is virtually identical to intravenous, except that it's going into the marrow cavity of the bone, which is very vascular, and it enters venous bloodstream rather quickly. Within 20 to 45 seconds of IV administration, you'll have the same effects from IO administration. It requires a specialized needle and a specialized system to get the needle properly embedded into a bone. It's typically used for unconscious patients where intravenous access is not available or is too difficult to obtain. Subcutaneous injections, SC, SQ, or subQ, is given beneath the dermis into the fatty tissue layer below the skin, in between the skin and the muscle. So you tend to pick areas where there's a little bit excess tissue to give subQ injections, or where you can pinch the tissue to get into that fatty tissue layer relatively easy. It has a relatively low or slow absorption rate and has relatively long-lasting effects. Insulin is a subQ injection. Epinephrine can be given subQ. In an emergency situation, we tend to give IM injections for epinephrine, so I'm not sure why they put that there. An intramuscular injection is injected directly into a muscle, preferably a large muscle, think thigh, glute, or deltoid. It's absorbed relatively quickly, slower than IV, faster than subQ. Not all medications can be given this way because of damaging effects to tissue, and some medications need a much more rapid onset of their effects than what can be achieved by intramuscular injections. Your EpiPens, most of your emergent epinephrine injections are going to be intramuscular. Mark 1 autoinjectors are used for organophosphate poisoning and cyano poisoning. Don't be concerned with that. That's beyond your scope, but it's an IM injection. It causes mild damage to the muscle, will typically cause bruising and some soreness. People who are in shock or who have compromised circulation, IM injections are not ideal because there's no way for the medication to end up in the venous system. So think about your person in anaphylactic shock, right? An EpiPen is an IM injection. If they're in anaphylactic shock and the blood has shunted all the blood toward the core, there's very little circulation out in the periphery. You inject it in the muscle, it doesn't go anywhere. It causes a little bit of localized effect, and it might eventually all get into the venous system, but it's going to take a long time because of that shunting of blood and shunting of circulation. So just understand that with somebody in shock, especially decompensated shock, IM injections are not necessarily reliable, and you may not expect to see the effects of the medication very quickly if you give an IM injection. The EpiPen is kind of the only example you'll have to worry about. Inhalation, so any medication that's absorbed through the alveoli of the lungs, it's breathed into the lungs, it's relatively rapidly absorbed. It helps to minimize the effects on certain parts of the body tissues, especially if it's a respiratory medication. If you're giving the medication for the respiratory tract, it's going to have a pronounced effect on the respiratory tract since you're breathing it in. And it will have a less significant effect on the rest of the body. It comes in various types: aerosols, powders, sprays. So like Afrin nasal spray is inhaled, not so much into the lungs, but into the nasal cavities. Aerosols are like your rescue inhalers and your small volume nebulizers. Some of the metered dose inhalers are actually fine powders, especially your long-acting corticosteroids for asthma and COPD. Sublingual is given into the vascular tissue underneath the tongue. It's relatively quick. It's not quite as fast as intravenous, but it's a more reliable source of circulation than IM. It's relatively painful, so when an injection would typically be given IM, but is not expected to work because of vascular collapse, it may be given sublingual. Keep in mind, epinephrine autoinjectors cannot be given sublingual. The needle is too large. You're going to destroy that tissue. But it's faster than oral administration. It's not quite as fast as typical IM injection, and certainly not as fast as IV injection, but it's relatively fast. In y'all's case, nitroglycerin tabs and spray are going to be your sublingual medication to discuss. Transcutaneous or transdermal, something that goes through the skin. It's typically applied as a patch or a cream, has very long-lasting effects. There's usually a very well-known absorption pattern, especially if they're put on the correct portion of the body. Nicotine patches are a good example. We also use nitroglycerin patches at a more advanced level. You may be able to use them at a basic level depending on your protocol. It basically just gives them a continuous infusion of nitroglycerin slowly through the skin. And then pain patches, fentanyl patches, lidocaine patches. I can't remember if morphine comes in a patch form, but a lot of different opiate pain medications for chronic pain management come in patch form. Intranasal is a type of inhaled medication. It's something that's blown up the nose, gets absorbed by the nasal mucosa as opposed to the alveoli. It's a special type of device that has to be used. It's typically a medication that would otherwise be given intravenously. You attach this device to it, and when you spray it through the device, it atomizes it, it aerosolizes the medication so that it can be easily absorbed by the nasal mucosa. What form the medication comes in is going to be kind of dependent on how you give it. Obviously, you can't give tablets or powders through an IV unless you reconstitute them first, but tablets, certainly not. The manufacturer kind of chooses what route they're going to use based off of what effects they're going for. So like they make morphine in tablet form, but they also make morphine in IV intravenous form. And the purpose for that is if it's in tablet form, you're wanting sort of a less pronounced effect, but over a longer period of time, whereas the intravenous form, you want a faster onset of the effect and a more significant effect, but it's just not going to last as long. So depending on what the goal of the medication is, the manufacturer, through studies and research, determines what the appropriate route of administration is. Tablets or capsules are given by mouth. They're enteral medications. Tablets are typically medication mixed with some sort of sugar base and compressed into a pill to be swallowed, whereas capsules are a small cellulose surrounding, watertight surrounding, with the medication inside. It's usually the capsules are usually designed so that they will get through the stomach before beginning digestion. So the capsule is designed to not dissolve in the stomach. It's designed to dissolve due to certain pancreatic enzymes in the small intestine. Solutions or suspensions. I think most parents probably understand this. The medication that you got to sit there and shake up forever before giving it. Amoxicillin is kind of a great version of it. Most of them can be given by any route because it's medication that's been constituted into a liquid form. It's usually relatively quickly absorbed in the digestive tract. And then there are certain IV, IM, and sub-Q injections that are in fact solutions or suspensions that have to be shaken ahead of time or have to be reconstituted ahead of time. Meter dose inhaler, we talked about these in lab. It's basically just every single time you press down on the canister, 1 dose of the medication is given. It's very specific on what disease process is going on, but they're most common in respiratory diseases such as asthma, emphysema, chronic bronchitis, COPD issues. Topical medications like lotions, creams, ointments, obviously they're going to be absorbed transdermally or potentially not really absorbed at all. Things like calamine lotion, it's just absorbed directly into the skin. It doesn't go any farther than that. Its target effect is right there at the skin. That's why it creates a crust. That crust continues to create a continuous effect at the location, but it doesn't really cause systemic effects. Keep on tapping down arrow on accident. Transcutaneous medications, it's anything that goes onto the skin and absorbs through the skin into the vascular system. Keep in mind that these medications will affect you just as much as they will affect your patient. So you should not handle them without gloves on, but even then, you need to recognize that some of them can be absorbed even through gloves. So if you're dealing with nitro paste or nitroglycerin paste or certain types of pain relievers, you must be wearing gloves to administer them, but as soon as you're finished administering the medication, the gloves need to come off and your hands need to be washed to make sure that any medication that got onto the gloves isn't going to be absorbed into your system as well. Gels, there's all sorts of different types of gels. Any type of medication can come in a gel form. It basically just prevents things from, or it allows them to stay in their location without coming off easily. Oral glucose is the only gel that y'all will have to worry about. And it's designed so that it doesn't become watery and swallowed immediately. It's meant to stay in their mouth temporarily. And then the gases for inhalation, oxygen, obviously. Nitronox or nitrous oxide are sometimes carried, or nitrous oxide is sometimes carried on ambulances and may be a basic skill. Oxygen should be carried on all ambulances. And it's given through a non-rebreather or a similar type mask. All right. Do not ever administer a medication that you do not have approval to administer without at least talking to medical control before administering it, okay? So if your protocol says, do not give this medication, don't give that medication. If it says you have permission to give these 10 medications, don't find an 11th medication and decide to give it because it's similar to one of those 10. If you think that that 11th medication might help the patient, but you don't have a protocol to do it, call medical control and say, hey, I've got this other medication available to me. Would it be okay if I use that? Okay, so keep that in mind. We talked about the 8 rights in lab. Right patient, pretty hard to screw up in EMS. You shouldn't be dealing with a whole host of patients in EMS when giving medications. Make sure that you've got the right medication. When you pull it out of a drug box, make sure that the medication you grabbed was the medication you intended to grab and the medication you intended to administer. Make sure you're giving the right dose. You must know the doses in order to administer the medication. Not all medications come in a single dose package, so keep that in mind. Make sure you're giving it by the right route. Don't have people swallow IV morphine once you get to that level. Don't crush up aspirin powder or aspirin tablets and mix it with water into a paste and trying to give it transdermally. Make sure you're giving it by the route the medication was intended to be given by. Make sure you're giving it at the right time for the right reason. And make sure that you're not giving the medication too often if it's one that you can repeat every so often. Make sure that you're documenting appropriately. Make sure you document what was going on with your patient, why you decided to give the medication, what happened as a result of giving the medication, and whether or not there were any negative effects. Make sure that you educate your patient on what medication or treatment you plan to give them. That's the right to be educated, and then the right to refuse. Make sure you get consent from the patient to administer that medication and understand that they have the right to tell you, no, I don't want it. Common medications carried on the ambulance: oxygen, oral glucose, activated charcoal, aspirin, epinephrine auto-injectors, or epinephrine multi-dose injectors, or multi-dose vials, sorry. Those are pretty common. There are some others that may be allowed based off of your medical protocol, such as albuterol, Atrovent, nitroglycerin, naloxone, nitrous oxide. All of these are potential for you to see, but they're very based on the service. In the state of Texas, oxygen, oral glucose, aspirin, and epinephrine must be on a truck. Activated charcoal is not required, but it's common to see. So we'll talk about some of these. We're gonna skip patient-assisted administration real quick. Just understand on the patient-assisted administration. Sorry, there's one thing I did want to talk about. Oh my Lord, come on. Sorry, patient-assisted administration. Understand, a great indication to give a patient a medication that you know how to give or know why to give is that they're already prescribed that medication, right? So if somebody already is prescribed nitroglycerin for their chest pain and they're having chest pain, a great option would be to have them take their nitroglycerin. That is a good indication for giving a medication that they're already prescribed for. Okay, so keep that in mind. All right. EMT administered is medication administered directly by the EMT. Hopefully that makes sense. We're not going to talk about protocols further. These are the 5 most common medications that EMTs are allowed to give, and we'll talk about them specifically. And then there's others that you're able to give. Oh, man. We've already talked about this. All right. So giving medications. Make sure you've got your body substance isolation. Confirm the order. We talked about this in lab. Anytime you're given an order to give a medication, so assuming that you're talking to a medical director over the radio or anything like that, you're going to parrot that order back verbatim. If you're working with a paramedic and paramedic says, hey, I need you to administer 324 milligrams of aspirin, PO, you're going to repeat. Okay, I'm going to be administering 324 milligrams of aspirin, PO. Okay, you got to parrot it back. Make sure you confirm the 6 rights. It's usually a relatively quick confirmation that goes on almost subconsciously, but just make sure you're actually going through it. If you're giving an oral medication, make sure the patient has the ability to swallow. If they do not have the ability to swallow and you put something in their mouth, you have the potential to cause an airway complication. Activated charcoal, it is something that basically absorbs anything in the digestive tract and prevents it from being absorbed by the digestive tract. So somebody who's overdosed on a medication and you want to pick up as much of that medication as possible and prevent it from being absorbed by the intestinal tract, activated charcoal may be a good option. Okay. It's a suspension. It's incredibly finely powdered ground charcoal in sorbitol and water. Sorbitol is a non-caloric sweetener to hopefully A, make it taste a little bit better, and B, help the charcoal to move through the digestive tract quickly. It acts kind of like a fiber as well. It tastes horrible. It looks horrible. It turns their mouth black, turns their lips black, and most patients have a difficult time drinking it because it tastes awful. It will stain everything it touches, and there's virtually no way to get it out. So keep that in mind. Contraindications. So the indication for activated charcoal would be ingestion of poisonous substance or potentially harmful substance within the last 15 minutes. Okay. After about 15 minutes, activated charcoal becomes a little bit ineffective just because it doesn't have the ability to get to the same location in the digestive tract as the ingested poison. So, contraindications, reasons we do not give activated charcoal. The patient is altered mentally and they're at risk of aspirating. So, somebody who is not capable of protecting their own airway because of a mental status change cannot be given activated charcoal. It can cause vomiting, and because it can cause vomiting, we don't give it to anyone who has ingested a significant acid, significant base, or petroleum product, because we do not want that substance to re-damage the airway, esophagus, and mouth. If you're sort of not sure if activated charcoal is necessary for your patient, call poison control. Realistically, you ought to be calling poison control every time you identify an ingestion like that. The dose is 1 to 2 grams per kilogram. It's not too difficult. Most of the packages are dosed for an average individual between 1 and 2 grams per kilogram. So most of the time, people can have the entire package. To get the patient's weight in kilograms, just divide their pounds by 2.2, or divide by 2 and subtract 10%. So if someone's 200 pounds, you would divide by 2, now 100. 10% of that is 10. Subtract it from the original 100, and you get 90. So somebody who's 200 pounds is approximately 90 kilograms, approximately. That's a good way to estimate. All right, oral glucose. It's just glucose. It's sugar. It's an easily absorbed sugar. Hypoglycemia is low blood sugar caused by either excess insulin in the body or excess activity without increased sugar ingestion. So if we haven't been eating, but we've been exercising, we can cause ourselves to become hypoglycemic. But primarily it's due to an excess amount of insulin in the body, an accidental insulin overdose, or somebody who took insulin and then didn't eat the appropriate meals. Oral glucose is designed to correct that by introducing glucose into the system. The gel is placed in between the cheeks, the gum, and the teeth, and is designed to stay in that area. It's designed to be squeezed into the cheek and then kind of rubbed into the mucous membrane around the mouth to be absorbed. You don't necessarily want your patient swallowing oral glucose. If they do, it's not a problem. It just takes longer to absorb into the tract. And then, again, it's an oral medication, so it can't be given if they have the potential for airway compromise. So an altered LOC or potential airway compromise means don't give oral glucose. Okay. Aspirin. It's given for a number of different reasons. It's a fever reducer, it's a mild pain reliever, it's an anti-inflammatory, and it is an antiplatelet aggregation. It's not an anticoagulant. That's an incorrect thing right there. It's an antiplatelet aggregation or antiplatelet aggregate medication. It prevents clots from getting bigger than they already are, or helps to prevent them from growing in size. It's helpful during heart attacks or myocardial infarctions, so MIs. Generally speaking, in the EMS system, we don't give it as an antipyretic or an analgesic, not really even for an anti-inflammatory. Those are all good uses for it, and some services may use it for those reasons, but typically it's only used in the EMS for its anticoagulation properties or its antiplatelet aggregation properties. Some contraindications to it are hypersensitivity, so they're allergic to aspirin. It causes some sort of allergic reaction. If they have severe liver damage, if they have active asthma, so they're actively having some sort of asthma attack, or have recently had an asthma attack or are prone to having regular asthma attacks. We don't want to give aspirin because it has the potential to cause bronchial inflammation, especially if it gets breathed in while they're chewing it up. And then anyone who's actively bleeding. Any active bleeding known, don't give aspirin. So if they say they have a bleeding ulcer, bleeding GI ulcer, they have any sort of GI bleed, if they've coughed up blood, if they've recently had any bloody stools, anything like that, don't give aspirin because it'll cause that bleeding to worsen. And then any children that have a fever, it has the potential to cause Reyes syndrome, which is a host of symptoms caused by administration of aspirin during a fever, during an illness that results in a fever. So, generally speaking, we don't give aspirin to kids. Sublingual medications, there's really only one that we have to worry about, and that's nitroglycerin. Kind of the same idea. It's still going into the mouth, so we've got to be worried about the airway, but less worried about the airway, especially if it's in a spray form. Small nitroglycerin tabs can potentially cause airway problems, but they're significantly smaller than any of the main airway passages. So even if they do end up in the lungs, they will dissolve, break up, and move further down in the airway passages, so we're not too concerned about it. They can choke and slightly and cough on the pill, but it's not large enough to cause a true airway obstruction. But generally speaking, we don't want them to be unconscious if we're going to be giving them a sublingual medication like nitroglycerin. So, nitroglycerin is used to treat chest pain. It's used to treat stable and unstable angina. It helps to resolve spasms of the coronary vessels, relaxes the vessels, decreases blood pressure, and decreases workload on the heart. Prior to giving administration, you need to know a couple things. The blood pressure must be at least 100 systolic. Me personally, I don't give it below 110 simply because I'm used to seeing approximately a 20 millimeter of mercury drop after nitro administration. And we do not want their blood pressure to ever get below 90, except in very specific situations that you'll learn about later in your career. So we don't want to give nitroglycerin and cause them to become hypotensive. Okay. The head of the bed ought to be slightly elevated because of the vasodilation that occurs. If they're laying down, they'll get a severe headache and a lot of blood will rush to the head, and it's just very uncomfortable. Sitting them up will help minimize that effect. It also helps minimize the potential for them to choke on the pill. If the patient becomes dizzy after administration of nitroglycerin, check their vital signs, identify whether or not they've become hypotensive. If they have, treat for shock or treat for hypotension. It will probably resolve in a few minutes, but it may cause issues while it's going on. If chest pain is not relieved by nitroglycerin, find out how many times the patient has taken the nitroglycerin to try and relieve that pain. If it's been 3 or more, assume that they're having a heart attack. If they haven't taken any and you've given them 1 and they haven't improved, you may have orders to give more. Identify whether or not they might be wearing a nitro patch. We don't want to be giving oral nitroglycerin to somebody who's had a nitro patch for a long period of time. That extra nitroglycerin is not going to do any good. And if they've experienced more than what their doctor said, or if they've exceeded how many pills their doctor has told them to take before going to the hospital, don't give them any more, just get them to the hospital. Anytime we're giving nitroglycerin, ask any patient about erectile dysfunction meds or pulmonary hypertension medications. So these 3 medications, sildenafil, tadalafil, and vardenafil, Viagra, Cialis, and Levitra, are all given for erectile dysfunction, but they started their progress to become drugs as pulmonary hypertension medications. And it just so happens that a whole bunch of guys started reporting an unexpected side effect. Every time I take this medication, I get an erection. So they found out that was going on and said, hey, maybe we can make more money on this medication by selling it this way. but they are still used for pulmonary hypertension. That's why we ask female patients about them as well. Don't ask a female patient if she takes an erectile dysfunction medication. That doesn't make any sense. Ask her if she takes sildenafil, tadalafil, or vardenafil, which happen to be Viagra, Cialis, or Levitra, for any sort of pulmonary hypertension. If the patient has had any of these medications within the last 24 hours, do not give nitroglycerin because it has the potential to cause severe hypotension and severe complications as a result. It relaxes coronary vessels, relaxes the vasculature of the body to help bring down blood pressure, bring down cardiac workload. It's given sublingually. It's a small tab or spray given underneath the tongue. They're not supposed to swallow the pill if you have the pill form. It's not supposed to be used if it's expired. If it's been exposed to a bunch of light, it's not supposed to be used. So it needs to be stored in a dark brown glass in an area protected from light as best as possible. You should always wait 5 minutes before repeating a dose and identifying whether or not the symptoms have improved. If they've improved, don't give any more. If they haven't, give the next dose. Repeat doses must be approved by your protocol or directly by your medical director. Always wear gloves. These medications can be absorbed into the skin just like a transdermal medication, since obviously we give nitroglycerin in a paste form as well. It can be absorbed through the skin. Okay, what's going on? Just 1 second. Hold on. It can be given as a spray or a tab. Both of them can be absorbed into the skin. Always wear gloves and make sure you remove those gloves afterwards. Hold on! I apologize about that. Y'all are knocking on the door and not letting me finish. Oxygen should be given per protocol for anybody with chest pain, so keep that in mind. IM injections, the only one y'all really have to worry about is the IM epinephrine auto-injector. It's quick, it's easy access. Blood flow to the muscles is relatively stable so long as the patient is not in shock. Don't give IM injections in an area that's significantly damaged because you may not have good return circulation. The needle causes pain, causes fear, things like that. So be considerate of that when giving these medications. So epinephrine is a sympathomimetic, meaning it mimics the sympathetic nervous system. It does the same things that the sympathetic nervous system would do. It is effectively adrenaline. It's effectively the exact same medication, or the exact same chemical. It typically tends to increase the heart rate. It constricts blood vessels of the skin and the digestive tract. It dilates the bronchioles, dilates the smooth muscle, and decreases inflammation of the bronchioles to help ease breathing problems during an asthma attack or during an allergic reaction, anaphylactic reaction. It also helps to maintain blood pressure by helping to close those blood vessels and shunt blood back toward the core in anaphylactic shock. Contraindications to epinephrine: they are significantly hypertensive, if they are significantly tachycardic, if they are hypothermic, because they won't have any blood circulation to their distal extremities, if they're having a myocardial infarction. I don't know why we have to discuss that one as a contraindication. I don't know why you would want to increase the heart rate of somebody having a heart attack, but we got to put it on there. And if you don't identify any sort of respiratory problem, don't give epinephrine. Okay. Kind of talked about that. It's dispensed from an auto-injector at the basic level, 0.3 milligrams for adults, 0.15 milligrams for children. The service that you work for may allow you to draw up epinephrine from a vial and give the IM injection differently, but that training will be dependent on the service. It's not something you'll learn in this course. It can cause some burning at the injection site due to localized vasoconstriction. It tends to cause tachycardia, anxiety, jitteriness, things like that. Naloxone is what we're talking about. It's a narcotic competitive antagonist. It's used to reverse narcotic overdoses, or respiratory depression as a result of narcotic use. The minimum dosage is 0.4 milligrams. The max single dose is 2 milligrams, typically given 0.4 to 0.5 milligrams at a time in intermittent doses until you see improvement in respiratory quality. It should be given slowly in the smallest appropriate dose to avoid sudden onset of violent behavior, avoid withdrawal symptoms of somebody who takes pain medications regularly, help prevent seizures as a result of sudden onset of opiate withdrawal, and to prevent cardiac arrest for the same reason. Okay, nebulizers, talked about those already. Narcan can be given as an intranasal spray, but typically is given IM. The intranasal spray would be if they're in more significant shock, or if you're having a hard time getting an IM injection. Oxygen, we've talked about oxygen plenty. I'm not going to go over oxygen again. MDIs, we don't carry MDIs on the truck. Just know that you may be able to help a patient take their metered dose inhaler, especially if their anxiety level or their panic level is too high for them to function appropriately. A lot of times spacers are used to help deliver the dose by separating it into more air so the patient takes a deeper breath in order to get all the medication. Some common asthma inhalers: albuterol, Atrovent, Flovent, Xopenex, Combivent, Alupent, Pulmicort. All of them are versions of these medications. Beta-2 agonists. These are albuterol, Alupent, or metoprolol. They are similar to epinephrine with fewer side effects, and they are meant to be nebulized and inhaled. Lots of people have different inhalers. Be aware that those different inhalers might give you some clue as to what sort of medical condition they have. Corticosteroids, mucolytics, and mast cell stabilizers. Those are not quick-acting medications. The beta-2 agonists are the quick-acting medications. So, small volume nebulizers are a little bit easier to use than an MDI. They take longer to complete the treatment, and they tend to be a little bit more effective. They require a compressed air source or compressed oxygen to be delivered. On an ambulance, we're obviously going to use the compressed oxygen. They can be used through a CPAP or through a BVM with a specialized adapter, so keep that in mind if you have those available to you. I'm going to go through taking a sample history. You need to know the types of errors that tend to be common. There's the knowledge base error, choosing an incorrect medication, choosing an incorrect dose, or doing something incorrectly because you didn't understand what you were doing. Again, this should never happen because you should not be giving a medication that you don't know about already. If you don't know the dose, if you don't know what the medication does, if you don't know the side effects and the contraindications, you should not be giving that medication. Rule-based error is you understand all of that stuff, but then you give it differently than you're supposed to for some reason that's inappropriate. And then a skills-based error is giving it incorrectly on accident, not recognizing that you did it incorrectly, thinking you knew you did it correctly, and you weren't. We'll cover each of these medications kind of as we go through the medical lectures, so don't get too caught up into learning all of it perfectly. Focus more on the definitions provided in the PowerPoint and the lecture. I don't remember how to end this recording.